Our first debate features Ron Plotnick and Rachel Wozniak, two of our corneal faculty, who I want to personally thank for taking care of a lot of my tough kids over the years. Ron's a clinical professor of ophthalmology and cornea specialist who joined the University of Rochester even longer than Dave and I in 1991. His practice includes medical management of corneal disease with specializations in dry eye and herpetic disease. He completed his undergraduate training in medical school, also at the University of Michigan, and his residency in ophthalmology at the University of Wisconsin. From there, he went to do his fellowship at UC Irvine before coming to Rochester. He's earned his master's in medical management and MBA at the Simon School, and is an essential part of our operations team has helped the department employ lean business practices that have optimized our efficiency. Rachel has recently been promoted to Associate Professor of Ophthalmology, congratulations, and is an integral part of our cornea service. She's an accomplished surgeon and has recently taken over the directorship of our residency program. Again, thank you for that. As a clinician scientist, Rachel has an interest in developing novel therapies to treat corneal infections. Her work has resulted in multiple publications and grants, including a K Award from the National Eye Institute and a Career Development Award from RPB. She has also patented novel treatment strategies for corneal infections. Rachel received her medical degree and doctorate in molecular genetics at Tufts, and then she came to Rochester for her residency and completed her subspecialty fellowship in cornea and external disease here as a HEED fellow as well. So please welcome Rachel and Ron as they present our first Ross debate of the day, PCR and culture versus empiric treatment of conjunctivitis.
Good morning. Matt, I've been here 32 years, but I went to UC Davis to do my fellowship. So just throwing it out there. We're going to talk today about cultures in cases of routine presumed conjunctivitis, which transfers over to treating empirically, essentially based on symptoms. So just a little background, busy slides, but irritation, itching, foreign body sensation, watering or discharge. Often, especially in adults, we treat empirically based on clinical suspicion that the conjunctivitis is bacterial. And if we kind of assume that if it is viral, we're not really hurting too much by treating the bacterial on top of it. In adults, bacterial conjunctivitis is actually less common than viral conjunctivitis, and opposite in children. 8 to 75% of acute conjunctivitis is viral. The typical bacteria are strep, NH flu, sometimes staph, and in children, H flu, strep, and Moraxella. Most of these, however, are self-limited. That is, you don't do anything for any of these, and they typically go away in 2 to 5 days. Not always, but you can always add treatment at that point if you need to. The aim of intervention early is to achieve rapid cure and prevent complications of infection. So who treats conjunctivitis? Well, it's not just eye doctors. We have pediatricians, primary eye care providers, NPs, PAs, urgent care centers, EDs, primary and secondary eye care providers, tertiary eye care providers, telemedicine encounters, and more than 80% of all acute cases are diagnosed by non-ophthalmologists. And, you know, when you look at the individual medicines like Tobrex and things like that, about 80% are used by the people in the list as opposed to eye providers. So rule out questions. Is it really infectious conjunctivitis? And a lot of this can actually be done by telemedicine. So we're not talking about treating people who are high risk. We're talking about treating people who are low risk, which is the vast majority of these patients. So questions, visual loss, any degree of visual loss? No, not likely to be conjunctivitis, needs to be seen, maybe needs to be cultured depending. Pain grading, a little pain's okay, but no more. Same for light sensitivity. Discharge characteristics can help you make a decision, but it's not always that accurate. I mean, sometimes viral can be very purulent, sometimes bacteria can be very watery, and whether it's one eye or two, I have not found to be very helpful. If they have a recent fever, URI, or other history, that would suggest that it's like a viral conjunctivitis. If they have recent cold sores or shingles, then I wouldn't treat those people. And some people will come in complaining of swelling in a preauricular node. So this comes from a primary care journal, which basically uses this algorithm, depending on visual loss or no visual loss, to sort of come down and figure out, you know, whether we should treat them or not, depending on what they have is likely to be the cause of their symptoms. I don't think it's accurate, but not inclusive when you go through it step by step. Cultures for all. So I'm going to argue no, that determining the exact cause of conjunctivitis can be a challenge. Bacterial, viral, allergic, fungal. The diagnostic tests are expensive and are not always available. Remember, 80% are non-eye care providers, which means that they have to have in their office either PCR or culture materials and expertise. Empiric treatment ensures that patients receive timely intervention, even in the absence of confirmatory tests, and nothing says you can't do a confirmatory test once you start if things don't go well. Conjunctivitis can cause significant symptoms, and by treating empirically, you can achieve your goal of preventing complications, improving patient comfort, and relief of symptoms. So prevention of complications. So delayed or inadequate management of conjunctivitis can lead to morbidity. So if you're doing PCR for something in the office, then you may be able to get that result right away. But if you need to send that off or send the culture off and drive it there at the end of the day, for instance, wherever your cultures are read, it's an unnecessary delay for most patients. So it's cost effective. If you think about how much you would spend to do PCR or fungus on all of these patients, you're taking away healthcare dollars from other places where it could be used, in my opinion, more positively. You also have false positives and negatives, as well as normal flora in those cultures. Time consuming, and you have to collect the sample, you have to have some expertise, there's additional costs. And then this is a big too, limited impact on treatment decisions. So because of those false negatives and positives, because we can really make fairly good decisions, it's very rarely do we change treatments or we make a mistake where we should have cultured and not treated. So the high prevalence of viral causes, basically, unless you're doing PCR for that particular virus, you essentially don't have a way of culturing that in any kind of timely manner. Whereas for bacteria, you got a couple days. The clinical diagnosis reliability, experienced healthcare providers can often diagnose conjunctivitis just based on the symptoms, sometimes not, but you do very little damage for most of these patients by treating empirically. Okay, so just I want to be real quick here on the drill down questions. So are cultures and other point of care testing for conjunctivitis immediate, sensitive, specific, inexpensive, and not resource intensive? That's not true in the vast majority of cases. Which providers have point of care testing immediately available to them? Cultures, PCR, other types of staining, very few. Do culture results influence treatment? Not that often. Do cultures require special training or skills and the eye care provider to be transport and other facilities for that culture? Typically, yes. Which of our tests do not require a delay? Well, PCR. So the more we have PCR and the faster we can do it and the more cheaply we can do it, there may be a time when doing PCR does make sense for all conjunctivitis. But looking at it now, what it costs and sort of the large footprint that it has, would have to be in offices. It's just not realistic. What culture types would we have to get to cover most cases of conjunctivitis? So here we use e-swab, and then it's cultured aerobic, anaerobic fungus, acanthamoeba, acid fast. I mean, you can sort of decide how far out you're going to go. What are we culturing for? Well, really just a few viruses and a few bacteria. So you kind of know what you're dealing with anyway. What conditions are we worried about missing? HSV? Probably. A corneal ulcer, that's the beginning of an ulcer that, the patient didn't have the appropriate symptoms to put them on the corneal involvement with those early questions we talked about. So, most of those are screened by those, that initial chief complaint in HPI, but not all. What outcomes have a worse outcome? What conditions have a worse outcome if not treated correctly? Corneal conditions, basically, infections and ulcers. Are there patient groups that we can identify who would benefit from cultures? Some people say infants. Certainly if they're getting worse, they're not responding to therapy, But for run of the mill, which is most of the people, it's pretty hard to know who to get cultures for and who not to. What are the costs of culturating? So this is from 2020, $857 million spent annually in the US. That's for treatment and cultures, but just, it's not a small number, but it's not a huge number, but it's a very small condition, taking up a lot of resources. So time, cost, availability, utility, and practicality are my arguments to not culture patients routinely. I don't even culture them if they're in my office routinely, if I think I know what they have, but that also gives you the benefit of having a slit lamp exam. So, and I'm certainly not saying that no one should be cultured. I'm just saying that we can screen fairly well those people who have more serious conditions. And there are articles that say this. So there are arguments pro and con. This has been debated before. Even though it's probably not my job, I'd say a mixed approach is probably best. But don't culture.
Perfect. So is this sharing already then? How do I know if it's sharing? Oh, it is sharing? Okay, awesome. Thank you. All right, so my job was to argue with Ron, which is one of my favorite things to do. So I accept the challenge. So I'm going to argue for the case for, yes, you should culture in cases of conjunctivitis. Okay. First of all, accuracy. Okay. People who come in with conjunctivitis tend to look the same, right? They've got injection, they're tearing, they have some discharge, and maybe their eyes are itchy, they have some blurred vision. It is, in my opinion, almost impossible to nail the etiology of that conjunctivitis just by your slit lamp exam, right? So you're going to guess, right? So what are you supposed to do? Just pick something, right? And what are you going to pick? You could pick something that's ineffective. You could pick something that gives the patient side effects. You're going to make the patient spend money on a prescription, right? You also have to make the patient go to the pharmacy, pick that up, and use the drops. So that's inconvenience. And then you have the, a situation your patients might not even use the drops. So you have an adherence issue as well. And so in addition to just guessing, which we don't really want to do in medicine, sort of this issue, which is, as you all know, very near and dear to my heart, is antibiotic resistance, right? Because when people are sort of prescribed something for conjunctivitis, typically the go-to is a topical antibiotic, right? But the reality is antibiotic resistance is a profound issue, and it's a profound issue here at U of R. A couple of years ago, I did a survey of all Staph aureus isolates that were cultured from eyes at the Flaum Eye Institute. And this was from 2019-ish, so we're already a few years ago now. But at that time, already a quarter of all isolates were resistant to moxifloxacin, and ciprofloxacin, which is one of those go-tos for conjunctivitis, is already at 50%. So if you think about what are the most common bacteria on the skin and around the eye and likely to infect the eye, which is typically a gram-positive, like Staph aureus, prescribing ciprofloxacin is really like, you might as well just prescribe, tears or saline. They're not going to work. And so we have a responsibility in antibiotic stewardship to not just kind of ubiquitously prescribe antibiotics, right? And the reality is, just to give you a little kind of background here, there hasn't been a new ophthalmic antibiotic that has come to market in over 10 years. So there's no backup plan, right? So when everything becomes resistant to moxi, there's really no alternatives. So we really should be very thoughtful about when we prescribe those antibiotics. And also the reality is most conjunctivitis is viral or allergic anyway, so you really don't need antibiotics. It's not treating anything, right? So I'm going to say that doing cultures is actually easy and cheap, and counter to what Ron suggested. And the reason I said that is that everyone, including primary care offices, EDs, urgent cares, have little swabs, right? They're super cheap. Every office has them. It's really easy to take a conjunctival swab. You don't need a degree in ophthalmology to do that. So the access to those swabs and the access to culture is actually really common and really easy. And this is something that the insurance's coverage is the standard. Okay, so I would say that the cost of culturing to the patient is actually less than what they're going to spend on the antibiotic at the pharmacy. So what should you do? So you see the patient, they have some conjunctivitis, you do the culture. What will you do in the meantime? Because we know that most cases are viral or allergic, a lot of these are self-limiting diseases. Artificial tears and a little bit of time does the trick, right? But if you're not sure, you can follow them a little closely, right? In that way, if they're getting worse, you can intervene. So my suggestion and my overall sort of recommendations is that in mild cases of conjunctivitis, and maybe moderate, which is the vast majority of cases of conjunctivitis, take a culture and do conservative management. Have them use tears, have them come back, sooner rather than later if you're worried at all. This is going to allow you to have improved accuracy. So you know exactly what you're treating. You're going to reassure your patients that you're not just guessing, right? You're giving them an accurate diagnosis. We're going to play our part in stemming the rise of antibiotic resistance in our community. We're going to save our patients money because they don't have to buy drugs, and we're saving them unnecessary side effects from those antibiotics. Cultures can be done anywhere, so that's, it's accessible to all. And so my argument then is, why not culture, right? For all of those reasons. And of course, I'll always put the caveat, just kind of have Ron had his caveat. If you have a case of serious conjunctivitis, it's a very purulent, the eye looks cloudy, vision is gone, pain is severe. That's obviously a more rare presentation of conjunctivitis, and one that you would take seriously. And in those cases, I would support, still doing your culture, but going ahead and proceeding with some empiric treatment just based on the severity of the disease. But I would argue that that's probably the smaller number of patients that present to our office with conjunctivitis. And so with that, I'll say thank you, and please culture all your patients.
Our next presentation is features two of our internationally experienced anterior segment surgeons who recently joined the Flaum Institute. Yor Chelik is a member of our growing comprehensive ophthalmology service who also has extensive experience in corneal surgery. Besides being an excellent cataract surgeon, Yor also performs corneal cross-linking and refractive surgery. He's a graduate of the Marmara University School of Medicine in Istanbul, and he completed his ophthalmology residency at BioU Eye Research and Training Hospital. He followed his residency with a fellowship in cornea, cataract, and refractive surgery at the Istanbul Medeniyet University. He then came to the U.S. to complete additional fellowship at Bascom Palmer. He's published more than 40 peer-reviewed articles and participated in early clinical research for corneal cross-linking. Esteban Santiago is an internationally trained cornea specialist. He joined our faculty last July after completing a cornea and external disease fellowship here at Flaum. He did his medical training at Argentina's Institute of Health Sciences. He then completed his ophthalmology residency at the Universidad Maimonides in Buenos Aires. He practiced cornea and anterior segment surgery there for 4 years before traveling to Canada to complete his cornea fellowship at the University of Ottawa. He is one of a handful of specialists in the Northeast who enjoys the challenge of complicated pediatric corneal surgery. He's a great addition to our team as well. Please enjoy the Ross debate presenting triple procedure versus sequential surgery in Fuchs. Looks like yours up first.
Morning, everybody. I will be a part of the debate today in triple DMEG in Fuchs surgery, and I will advocate a triple, and I have no conflict of interest. And I want to mention a little bit about the history of the triple surgery and the DMEG surgery. In 1976, triple procedure first announced with Dr. Daniel Taylor. And in 2004, Dr. Melas then described a procedure where the descemet membrane and endothelium were stripped from the host cornea and replaced with a donor button consisting of posterior stroma, descemet membrane, and endothelium. And in 2005, Dr. Francis Price was the first published clinical results of the technique, which he named the descemet stripping endothelial keratoplasty. In 2006, Dr. McGoroway reported the use of the microkeratome for donor dissection and coined the term descemet stripping automated endothelial keratoplasty. In 2006, Dr. Melas again developed another technique that he named descemet membrane endothelial keratoplasty. And in 2007, Dr. Chen published a new triple procedure because the first triple procedure was including the penetrating keratoplasty. If we review what is the penetrating and the DSAG and the DMAG, we change all cornea parts in penetrating keratoplasty. In desmoid stripping automated endothelial keratoplasty, we changed endothelium, we changed the desmoid membrane and a little bit from the stroma. And in desmoid membrane and the patellar keratoplasty, we only changed the membrane and the endothelium. I have a video from Dr. Rachel Wozniak. It's a triple procedure. The phaco part is taking the first part. The phaco part in a high volume surgery center will take the 8 to 15 minutes, and it will just extend your surgery 8 to 15 minutes. And all the steps is regular, except you have to be careful for the anterior capsular exercise because you want to be sure the lens is in its position during the surgery. And after finishing the first part, the DMAG part is starting with the myostatic agent like Myocol or Myostat. And after that part, surgeon is opening a small peripheric iridectomy to protect from the pupillary block because of your gas injection. And after that, we marking the cornea in appropriate size for our presumed transplant. And after that, we use the reverse Sinski to strip the desmoid membrane from its place. And then we remove that desmoid membrane with special instruments. And then we remove the viscoelastic from the anterior chamber because we don't want the viscoelastic during our implantation. And after that, we want to do double check with to be sure there's no desmoid membrane remaining. And after we clean all the trypan blue and the viscoelastic material, now we enlarge the main incision a little bit to put our Jones tubes head in good position to the cornea. This stage is very critical. It is because the tube includes the desmoid membrane and endothelium, and the surgeon is very, very careful, and all steps should be slowly. And after removing the Jones tubes, we want to be sure the main incision is closed, and we put the suture. And the repositioning of the endothelium is the next step. It may be sometimes challenging, it may be sometimes easier. And for a high volume surgeon like Dr. Wozniak, it is not that much long time. And you see that? And after that, we put the gas and the SF6 for 20%. And we need to wait 10 minutes to seal it. And 10 minutes after, we put the decompress the anterior chamber pressure, and we put the antibiotic, and the surgery is done. And let's talk about the advantages of the triple DMAG. Rapid visual recovery for the same surgery outcome. Triple procedure, patient's healing process is just starting from the surgery because you do everything at the same time. In sequential surgery, patient needs to wait the outcome after 2 separate surgeries outcome. I mean, they need to wait for cataract, they need to wait for the transplant. In a study, 203 eyes included, 149 triple, 54 sequential, and they noted that the knee triple procedure rapid visual recovery and allows selection of an appropriate intraocular lens. Another study is 77 eyes included, 37 triple, 40 sequential, visual outcomes, and endothelial cell loss and the rebubbling rate are not statistically significant different in the outcomes of between 2 groups. Another review study, this is a huge study, 11,401 eyes included in this study, and DMAG has a similar postoperative complication risk compared to triple DMAG. And another advantage is the limits the cost of the treatment. Use of a triple procedure rather than the sequential surgery will reduce the overall healthcare cost and will reduce the surgical risk of the patient by eliminating the extra trip to the operating room. I took this information from our billing department. Thank you, billing department. And they gave me only cataract surgery. It's almost $11,000, and only DMEC surgery, it is $23,700, and triple surgery is $25,000. And you see, it's cheaper. Another one, cheaper than when you calculate. And another one, the predictable refractive outcome. According to our baseline information that we have in the literature, in the past history of DMEC surgeries and in the reports, we know that the studies show the refractive shifts of plus 0.71 dioptry in patients who underwent DSAC after cataract surgery, whereas a shift 1.15 dioptry has been seen in the combined surgery. And the amount of hyperopic shift is less in DMEC because of the thinner lenticle. The hyperopic shift can range from 0.30 dioptry to greater to 0.50 dioptry. Conclusion. Given the high incidence of both Fuchs corneal dystrophy and cataracts, patients may present with varying stages of both conditions simultaneously. DMEC and cataract surgery remain the standard of care for these conditions respectively. A diagnostic approach based on the patient's history and clinical examination needs to be considered. This may help corneal surgeons in choosing between DMEC and cataract surgery alone in combination or sequential for optimizing management for these patients. The mixed results in the literature suggest that the decision to perform a stage versus combined procedure should be based on surgeon experience. This is an important point. However, if the patient clinic is compatible with both approach, why should the patient pay more, pain more, wait more, and suffer more? And I want to say my special thanks to Rachel, Naveen, and Dr. Macri and Dr. Delaroto, because I started DMEC surgeries last year, and all of these team is supporting me. Thank you.
Okay, thank you very much for this opportunity to present at this meeting. I'm going to defend the sequential surgery in this discussion. I have no conflicts in this talk. I will just say, Dr. Chelik said, gave a very well introduction. I will just say that because, as we can see in these OCT images, the DMEC tissue is so much thinner than the DSAC tissue, we have a few advantages, and that's that the patient will recover much faster. The final visual acuity is going to be a lot better. And there are a faster visual recovery as well, and less risk for rejections. When we're thinking operating a patient, a phakic patient with DMEC, we are thinking in doing two options mainly. We can do a triple procedure, or we can do a stage surgery. By doing a triple procedure, we do cataract surgery plus IOL implantation plus DMEC, or we can stage this surgery and do cataract and DMEC in 2 different times. I'm going to defend the stage. And here we have basically 2 options. We can do cataract surgery first, wait for 2 or 3 weeks, and then proceed with DMEC, or we can do the opposite, do DMEC first, wait for around 3 months, and then proceed with cataract surgery. We're going to talk about both of them, but we're going to start with the first one, which is cataract surgery first, followed by DMEC. And the question here is, do we have any benefit over triple? Of course, in this talk, the answer is going to be yes, we do. And the first one is going to be that the IOL complex is going to be more stable for the time of DMEC procedure. And because the IOL complex is going to be more stable, there's going to be a lower risk for the IOL to prolapse into anterior chamber and to get in touch with the new endothelium, which could be potentially devastating for this new endothelium. The anterior chamber is going to be more quiet. We are going to have a better pupillary constriction. We are going to have no pigment, no blood, and no fibrin into the anterior chamber. And this is going to make it easier when we have to insert the tissue, position, unfold, and bubble this tissue. And we're going to give time to the cornea to clear up in between surgeries. And this might be the most important benefit in this group. There are several papers written in this regard. This first one from Sitzman et al., they reported that over 90% of their patients with Fuchs dystrophy didn't require corneal transplant for the first year after cataract surgery. Chu et al. Reported in Nature that 25% of their patients that were already booked for DMEC surgery decided to postpone the procedure due to satisfactory improvement in best corrected visual acuity. This group reported in the retrospective review that 9% of their patients with Fuchs dystrophy, only 9% of their patients with Fuchs dystrophy developed endothelial failure after cataract surgery. And finally, this report coming from the University of Montreal, they reported that out of 222 eyes with Fuchs dystrophy, 1.2% require corneal transplant within 2 years following cataract surgery. So as we can see, most of the patients will not decompensate, and there are many patients that we think that they would need a DMEC, but they are actually happy with the visual recovery after cataract surgery only. So why not to give them an opportunity of avoiding a corneal transplant? The second approach is more of a refractive approach for DMEC surgery. We know that only 50 to 70% of the treated eyes are within 1 diopter of emmetropy after DMEC surgery, and this was first shown by Lazar et al., replicated by other authors. Because we know there are groups that have tried to develop formulas to optimize the IOL selection for these procedures. But a more reliable option would be to do the DMEC first, wait for around 3 months, do all the measurements, and then proceed with cataract surgery. Of course, this is going to depend on individual expectations and needs for each patient, and the presence of cataract and the age of the patient. By following this order, we could have a more predictable refractive outcome. We have the potential of offering presbyopia correcting lenses and toric lenses as well. And this was first shown by the Price group. And they showed very good refractive outcomes by following this order. And they implanted EDOF IOLs, bifocal IOLs, and toric IOLs in these patients. Are there any more benefits of sequential over triple? Of course, the answer is going to be yes, there are. And because time has continued advancing, technology has continued progressing, we're starting to see very good prospective papers on this regard. This was published last year, and they use OCT and an automatic software to detect and measure the descending detachment after DMEC surgery. And they compared the triple versus sequential surgery. They reported that in the triple group, they had a higher risk of severely increased IOP after surgery. The mean detachment was 126-fold higher in this group. Rebubbling was 3 times more common, and the graft detachment was more common near the clear corneal incision used for cataract surgery. So why should we stage DMEC then? It's a safer surgery with lower risk for complications. There is a lower risk for graft detachment and rebubbling. There is a high % of patients that might recover well after cataract surgery only. And we have more options to increase patient satisfaction. To conclude, there is more than one way to skin a cat. Options depend on patient's age, expectations, need, and examinations finding. And even though we have a great result with DMEC, there are many patients that can do very well after cataract surgery only. So why not to try for them to avoid a corneal transplant, or at least delay the corneal transplant? We could potentially be saving the money on chronic medication and saving money to the system as well. Thank you very much.
Our next cross debate involves our uveitis team, Wen Hu and Amde Shafira. Wen is an assistant professor of ophthalmology and splits her clinical time between treating both adults and children with uveitis and a cataract practice, where she performs complex surgeries on patients who suffer from inflammatory eye diseases. Wen received her medical training at Harvard, where she also completed a doctorate in neuroscience. She remained there for her residency in ophthalmology and went on to complete her fellowship in uveitis at the Moran Eye Center as a Heed Fellow. Wen's research interests include improving the diagnosis of infectious and malignant uveitis and improving outcomes in patients with uveitis undergoing cataract surgery. She has already received career development funding from the NIH for her research. Amde is an associate professor of ophthalmology and chief of the uveitis service here, where he provides medical care to adults suffering from inflammatory eye disease, including complications of autoimmune disorders. He received his medical degree from Addis Ababa University in Ethiopia. He practiced general medicine in Ethiopia until 1999 and rose to the medical director of the Wanji Hospital. He relocated to the United States in 1999 and completed his MS in clinical chemistry and PhD in microbiology and immunology at the Albert Einstein College of Medicine. He then went to the University of Florida, where he completed a residency in ophthalmology. And after completing a fellowship in uveitis and ocular inflammation at OHSU, he joined the faculty of our eye institute. His research interests include ocular sarcoidosis, birdshot chororetinitis, and various inflammatory and autoimmune diseases. And he has an extensive record of peer-reviewed publications and book chapters. Thanks for kind attention as they now come up and present local versus systemic steroids and complicated uveitis. Looks like Wen is first.
Thanks for having us. Amde and I are going to tell you today about steroids for uveitis. Steroids will treat inflammation, whatever variety. The question is, when do you use local steroids? When do you use systemic steroids? Hopefully, you'll have a good sense of that after our talks. So for my part of the talk, I'm local steroids. We're going to talk about the conditions in which you should think about using local steroids. What are the advantages of local steroids? And then most importantly, what are the risks and limitations to local steroids? So the local steroid options, we don't think about topicals, but technically they are local. We just give them out like candy here, but prednisolone, difluprednate, anything weaker than that doesn't really treat uveitis. Subtenons, triamcinolone, sort of next step up. And then you have a lot of intravitreal options. You have intravitreal triamcinolone or Triesence, lasts about a month or so. Dexamethasone, the injectable implant, also known as Ozurdex, that lasts 1 to 3 months. The fluocinolone acetonide injectable implant Utiq, this is about 3 or 4 years old. Now that lasts 3 years. And then the fluocinolone acetonide 0.59 surgical implant, that's the Retisert pellet, that lasts 3 years. That is a hefty, hefty dose of steroid for the eye. And then the newest formulation we have now is suprachoroidal delivery. So delivering triamcinolone via a proprietary needle into the suprachoroidal space. And we'll talk about that. So #1 rule of local steroids is you absolutely must rule out an infection. If you take away nothing from this talk other than this, I will be so happy. Amde and I will thank you forever. Once you give an injectable local steroid, you cannot take it back. And so if it is an infection, it is going to blossom before your eyes and you're going to be in big, big trouble. A few cautionary tales. Intermediate uveitis, got a subtenons triamcinolone. Then looked like this. This is Candida chorioretinitis, Candida endophthalmitis, really. This was a patient, post-op cataract surgery, persistent anterior uveitis, got a subtenons triamcinolone, blossomed, B-scan looks like this. This was C. acnes endophthalmitis. So if you have any concern, if it crosses your mind that there might be an infection, oral steroids, you can always take it away. So now when we talk about steroids, the question is, are you treating inflammation or are you treating macular edema? Because they are similar and they often go together, but they are not the same. So let's talk about macular edema. It's the leading cause of vision loss in patients with uveitis. About 40% of patients with intermediate posterior or pan-uveitis will get macular edema. About 20% anterior uveitis will also get macular edema. And it can persist or recur even though your inflammation is well controlled. So local steroids for the treatment of inflammation. I'm going to assume for the purpose of this talk, we've all tried the topical steroids and it's not working. That's why we're thinking about local steroids. We do not have good data comparing local therapy to systemic therapy, except, oh, I should say also, sorry, the Xipere, the suprachoroidal formulation is not FDA approved for the treatment of inflammation. It's approved for the treatment of macular edema. So we'll just take it off for now. We don't have good data comparing these options with systemic treatment, with the exception of the Retisert hefty dose of steroid, local steroid. And that's from the MUST trial, the multicenter uveitis steroid treatment trial. They randomized people to receiving the Retisert implant versus systemic treatment. So that included systemic steroids as well as systemic immunosuppression. And what you see here, if you're looking at control of inflammation, is that the Retisert implant actually does better up to 54 months, 4.5 years. You have better control of inflammation with the Retisert implant compared to systemic therapy. There are some caveats to this. We will talk about that. So I think cases in which local steroids are indicated and you should consider for inflammation, 17-year-old patient, intermediate uveitis, highly asymmetric disease, unilateral disease, I would say. Think about local steroids. You only have to treat one eye. You don't have to subject them to all the systemic side effects. This is a 55-year-old woman. She came in with vision loss in this eye a year ago and some sort of macular scar, then came to see me because she started losing vision in the other eye. She now has foveal involvement in the other eye. This, I think, is macular persistent placoid. This is a patient I gave oral steroids and an Ozurdex injection at the same time because she has vision-threatening foveal disease. I wanted as much inflammatory control on board as quickly as possible. This is another 53-year-old patient. She has birdshot chorioretinitis. She's on 3 immunosuppressive agents. She's on methotrexate, infliximab, and cyclosporin, and she's still active and leaking everywhere. This gets better when you give her steroid injections. And so this is someone who probably needs adjunctive local steroids on top of all of her immunosuppression. So active inflammation despite adequate systemic treatment. Think about adding local steroids. This is a 12-year-old girl with tubulointerstitial nephritis with uveitis. She was diagnosed appropriately, but she's just undertreated, undermanaged. She's been on oral steroids for over a year. She's 12, she's cushingoid. She has a lot of systemic side effects. As they're ramping up her immunosuppression, we decided to give her bilateral Ozurdex injections just to bridge her because we could not keep her on oral steroids any longer. So somebody who's having excessive side effects from systemic steroids. And Amde will talk to you more about what all of those are. This is a 30-year-old gentleman, panuveitis in both eyes. He unfortunately also has bladder cancer, and so did not want to go on systemic immunosuppression for that reason. And so he's been getting repeated bilateral injections of local steroids in both eyes. So someone who cannot receive or refuses systemic steroids or immunosuppression, or I would say also somebody who you don't think is reliable enough to come back and see you for follow-up because of all the toxicities of immunosuppression. You really have to monitor them. So in summary, cases in which I think local steroid for the treatment of inflammation, unilateral disease, when systemic therapy is insufficient, or there's a contraindication or intolerance to systemic treatment. And then let's just touch briefly on treatment of uveitic macular edema. I think this is where local steroids really shine, because even though you have adequate treatment of inflammation, the macular edema can persist. And you're not going to put someone on oral steroids forever and ever for the recurrent macular edema for years and years. So for macular edema, let's say, topical steroids aren't cutting it. These are your options. We don't have good data comparing all of these options. We do have one very good trial comparing sub-T non-triamcinolone to intravitreal triamcinolone and the intravitreal dexamethasone implant or Ozurdex. That is the POINT trial. It's periocular intravitreal corticosteroids for uveitic macular edema. If you look here, the darker bars are the intravitreal, the lighter bar is the sub-T nons, and you can see. And the conclusion of the study is that intravitreal steroids are equivalent to each other and they work better than sub-T non-triamcinolone. And so I would say for treatment of uveitic macular edema, I take subtenon triamcinolone out of the picture. These are your options. It'd be nice to maybe have some comparison between, the YUTIQ implant that's injectable you can do in the office compared to the Retisert, or even the newer study, the newer formulation of suprachoroidal. So I'd say, an example of somebody, this is a patient with multifocal choroiditis. She has highly asymmetric disease. You can see her little Ozurdex pellet that's remnant here, but she's relatively quiet. When the Ozurdex wears off, she's clinically inflammation-wise quiet, but she develops macular edema. So she's somebody who's been getting repeated Ozurdex injections, and we're trying to get her approved for the long-acting YUTIQ to see if that'll tide her over. So persistent or recurrent macular edema without any active inflammation, local steroids. So what are the disadvantages of local steroid? We already talked about one, which is that you can't take it away. Others that you might be familiar with, cataract. It depends, the incidence of cataract depends on what you give. The dexamethasone implant, in their study, it was a short follow-up, 6 months, but 15% of patients developed new cataract. They don't tell you how many needed surgery. The fluocinolone acetonide, the 3-year injectable implant, 33% underwent surgery within 12 months compared to about 5% in the sham group. And then the Retisert implant, 80% of patients got cataract surgery within 2 years. That's compared to about 30% with systemic treatment. Elevated pressures, we worry about steroid response. Depending on how much and how long you give steroids, lots of pressure problems. The more pressure problems you have, the more surgery you get. Endophthalmitis. We're trying to treat your inflammation, but you're also introducing a needle into the eye and a potential conduit for bacteria. Single-digit percentages. And then last but not least, cost. Prednisone, a course that Amde and I would prescribe for a patient, I looked up on GoodRx, $30. Triessence, $180. Ozurdex, $1,500. YUTIQ, $9,500. The Retisert surgical implant, $20,000. That's just the drug alone, not the surgery. Xipere, triamcinolone, $1,800. So in summary, you have to rule out your infections before any local steroid use. Long-term local steroid, at least the Retisert, the hefty dose, controls inflammation better than systemic therapy. Intravitreal steroids are superior to subtenon steroids for uveitic macular edema. And then local steroids are preferred for unilateral disease if you have inadequate systemic control, intolerance to systemic therapy, or if you have macular edema without active inflammation. Cataract and elevated IOP are the main risks and cost. Thank you.
Thank you, Matt, for inviting me, and also thank you, Steve, for your hard work organizing the conference. So I'll be talking about systemic steroids, the use of systemic steroids in uveitis. This table shows the various systemic steroids which are available in the US. The two that are widely used are prednisone and methylprednisolone. The prednisone is available in the form of tablets that range from 1 to 50 milligram, and it's also available in the form of a solution for children and for some adults who are, who cannot take pills. And the methylprednisolone is available in the form of solumedrol for IV administration. Oral steroids are quickly absorbed from the upper small intestine. They reach peak level within a few minutes, within about 30 minutes, and they are widely distributed throughout the body tissues. Prednisone is not active on its own. It has to be converted into prednisolone in the liver. So if patients have impaired liver function, it will be a good idea to use prednisolone rather than prednisone. Corticosteroids are converted in the liver into inactive metabolites. The plasma half-life of steroids is very short, but what's important is that the biological half-life is very long. For example, for prednisone, the half-life, the biological half-life is around 12 to 36 hours. So once daily administration could be, enough. This is just to show you the physiological dose of steroid. According to one study, the mean normal cortisol secretion, which is the endogenous steroids, is around 16 milligram per day. And based on potency, that's equivalent to around 4.1 milligram of prednisone. So based on that, about 5 milligram, or some people say 7.5 milligram, prednisone is considered to be physiological dose. So when do you use systemic steroids? So when we need a rapid control, for example, we can use it in patients with non-infectious intermediate uveitis, non-infectious posterior uveitis, or pan-uveitis, when we need a rapid control. In some cases, you just go directly for systemic steroid, for example, for VKH, for sympathetic ophthalmia, or Behçet's disease. We can also use systemic steroid in some cases of anterior uveitis. For example, if a patient with a Choroidal uveitis, if it doesn't respond quickly, if the patient has severe inflammation, it may be a good idea to use a short course of oral steroid. We use systemic steroids sometimes to prevent post-surgical uveitis if the patient has past history of uveitis. Sometimes we do use systemic steroids in cases of infectious uveitis after initiation of appropriate antimicrobial treatment. For example, ocular syphilis, ocular toxoplasmosis, or if you don't treat the inflammation, there could be a lot of tissue damage. So the starting dose for oral prednisone is between 0.5 to 1 milligram. Rarely you can go to 2 milligram in some cases. That's not common. I have had good success with 0.5 milligram. I'm afraid of side effects always. I will come to the side effects. So 0.5 to 1 milligram per day is a typical. And you have to taper down as soon as possible, at most by 3 months. And you target, if the patient has to stay on steroid after 3 months, the target is to bring them to 7.5 or below. If that's not possible, 10 milligram or below. As I mentioned previously, oral steroids are taken once a day in the morning after breakfast. If they take it at the end of, in the afternoon, it can affect their sleep. Sometimes you have to do it in divided doses because sometimes patients could have, symptoms, pain at the end of the day. So rarely you can do twice a day, but usually it's once a day. IV steroids can be given in 2 forms. You could do like pulse therapy, 1,000 milligram daily for 3 days, and you could repeat in about a month. Intraoperatively, you could give solumedrol to prevent post-surgical inflammation. The dose could range between 125 to 1,000 milligram. So the tapering regimen is different. This is according to Dr. Jobs. So if the dose is higher, between 30 to 60 milligram, you could taper by 10 milligram weekly. If it is a standard taper, if it is a rapid taper, you could taper every 2 days. Between 15 and 30 milligram, you decrease by 5 milligram. And between 7.5 and 15, you taper down by 2.5 milligram. As I mentioned, I'm afraid of side effects. I taper much faster than this one. So I have my own tapering regimen. But that's what most eye doctors do. You get some. So sometimes you might have to keep patients on a low dose of steroid. Is there any risk? So according to a study, if in patients taking 7.5 milligram daily for a long term, like for months to years, there's no side effect. But even though the physiologic dose is around 5 milligram, 7.5 milligram, if you keep patients for a long time, like for 22 years, 15 years, and there is some increased risk of cardiovascular disease and mortality. Contraindications, absolute contraindications for systemic steroids. If there's any known hypersensitivity, once in a while we'll see a patient who has steroid allergy. That does happen. And as Wayne mentioned, infection, if there's a systemic infection like fungal infection, TB, or ocular infection without appropriate antimicrobial coverage, that will be a no-no. Relative patients with, high blood pressure, congestive failure, psychosis, depression, active peptic ulcer, and poorly controlled diabetes, osteoporosis, and something like that. If you suspect lymphoma, you don't want to give, prednisone back because that will affect the diagnostic process. Side effect. Steroids have a lot of side effects. Almost, the whole body can be affected, including the eye. Like systemic steroids, can cause cataract, can cause glaucoma, can cause CSR. So, a lot of complete side effects. According to one study done on 208 patients with ocular inflammation who were on steroids, 12% of them got weight gain, 1.9% developed diabetes. That's a big number. 1.9% developed mood swings, 0.9% developed psychosis. That's a big deal. And 3.3% developed peptic ulcer. And around 1.4% each developed vertebral collapse and hip necrosis. Just an anecdote about peptic ulcer. You tell your patient steroid can cause peptic ulcer, but you cannot tell them everything. There's a lot of side effect. One doctor treated a patient with prednisone. The patient developed intestinal ulcer, down like around the ileum. Because of that, he had to undergo surgery, and he was not happy. He sued the doctor. So you'll not be able to tell them. It's a long list, but anyway, that's just a small anecdote. So one of the field complications of steroids is AVA. So this picture shows an actual head of the femur removed from a patient. It showed the cartilage coming off the head of the femur. So it's not common, but when it happens, it's very bad. I have met a patient who had AVN in both hips and in both shoulders. So when I saw him, he had both hips replaced, one shoulder replaced, and he was waiting for the third one to be replaced. So it's very rare, but it does happen. My former colleague, Dr. Thorne, would tell her patients, if you are afraid of being hit by lightning, don't go outside when it's raining. If you are afraid of getting AVN, don't take steroid. But so anyway, tell your patients, but don't, as far as possible, stay away from high doses. And 20 milligrams per day is considered to be a safe dose for AVN. So I quickly try to go below 20 as soon as possible. The other is osteoporosis. So in all patients, when you are starting them on prednisone, please start them on calcium and vitamin D at the same time. So calcium around 1200 milligrams and vitamin D around 800 units. If you are keeping them for more than 3 months, then talk about smoking cessation, alcohol consumption, weight-bearing exercise, and so on. Also consider adding a bisphosphonate. And also consider getting a baseline bone density measurement and then check that annually. The other is, if you keep patients on steroid for a long time, the adrenal gland starts making cortisol. So usually this is reversible. To prevent problem, taper slowly. And eventually, if the patient, if there's time to come off steroid, get a consult from endocrine doctor. So they could do ACTH stimulation test and they'll make an assessment if the patient can't come off steroid. And when during time of stress, such as illness, injury, surgery, this patient might need a supplemental steroid. Some considerations during pregnancy and childhood. Prednisone is a category C drug. So use only when the benefit outweighs the risk. There is a risk of the newborn having adrenal insufficiency. There is a risk of the baby being exposed to prednisone through breast milk, especially in high doses. And finally, there is a risk of impairment of growth because prednisone can affect bone growth. So in short, steroids are our best friends. Without steroid, probably there will not be a uveitis subspecialty, but they are our worst enemies. I have seen patients end up becoming totally blind because of steroid-induced glaucoma. So you could get a no light perception patient from steroid. You could get a handicapped patient from steroid, but if you are aware of the side effects, if you correctly manage your medication, so you should be able to avoid that. Thank you.
Our final Ross debate this morning is going to welcome two of our excellent comprehensive ophthalmologists, Christine Coward and Janice Lee. Christine is an associate professor of clinical ophthalmology and is the medical director of our new City of Rochester Goodwill location on South Clinton Ave, where she helps to integrate comprehensive ophthalmic care for the underserved with low vision services. Christine earned her medical degree from SUNY Downstate. She then completed her residency in ophthalmology at the New York Medical College, where she was chief resident. She completed a glaucoma fellowship at the Southern California Glaucoma Consultants before returning to New York to practice with Crystal Run Healthcare. She later moved to Rochester, practicing ophthalmology initially at Rochester Regional Health before joining the Flaum Institute. In addition to her work with underserved populations, she's actively involved in encouraging underrepresented minorities to pursue careers in science and medicine. Janice is an assistant professor of ophthalmology who is also part of the comprehensive eye service. She served her medical degree from Albert Einstein College of Medicine and completed her ophthalmology residency at Long Island Jewish Medical Center, where she was also chief resident. Prior to coming to Rochester, Dr. Lee practiced general ophthalmology in Bayside, New York, and Torrance, California. Please welcome Christine and Janice as they discuss office-based versus operating room surgery for cataract. Who's up first? Christine's up first.
Good morning, everybody. So I have to make a confession. When Janice and I were talking about who would do pros and who would do cons, I love learning about new technology. I love learning about new approaches. So I said, I don't really know that much about office-based cataract surgery. Let me tackle the pros. And then my confession number 2, completely self-serving. I'm going to ask Dave if I can have one of these for Christmas. At the South Clinton location. So just to get started, everybody knows the number of cataracts in the United States absolutely outnumbers the amount of surgeons tackling them. In 2016, cataracts affected 26 million Americans. 25% of these people were between the ages of 65 and 69, and more than 68% were over the age of 80. So we know that the cost of cataract surgery includes our fee, the surgeon fee, the anesthesiologist fee, but really the main cost is the facility fee. Medicare reimbursement averages for ASCs about $964. And these stats may not apply to this year because we all know that every year things keep going downward. But hospital reimbursement for facility fees is $1,670. So as with everything, there's evolution. Prior to 1985, patients were admitted to the hospital, were there for days for cataract surgery. Around 1985, there was an advent to move cataract surgery out of the hospital and into ASCs, and everything went into an uproar. There was a concern for safety, but it actually proved to improve patient satisfaction and also be a cost savings. The other evolution is the perspective of anesthesia. We used to put people to sleep using general anesthesia, and we know the side effects of those agents. And it moved from GA to retrobulbar to peribulbar anesthesia to topical. Present day, now we're looking at moving cataract surgery from ASC to in-office ORs and just moving to straight topical without IV sedation. So just for everyone's education, when I started to think about this before I did the research, I thought it was like a minor OR. In fact, this is a legit in-office OR suite. You can have them be accredited by multiple agencies, and they can check in on your office suite just to make sure that you're up to standards. You also follow the same sterility standards that ASCs use. And I don't have any financial interest in this, but there are companies that can help you set this up in less than 6 months. So I could have this by Christmas. So let's get into the advantages. So from a surgeon standpoint, there's increased control with an OBS. Your surgical facility fees can be retained by the surgeon practice. There is a disclaimer with this because these rules and these fees may vary by location. So I would advise anyone looking into this to find out what the rules are and consult your compliance experts or legal counsel. It streamlines the surgical process by shortening scheduling delays until surgery. You don't have to do any unnecessary pre-op testing. So goodbye CMP, BMP. And you also have the option of hiring an anesthesiologist if indicated for your particular patient. For the hospitals and the ASC, it does release very valuable OR capacity and resources. And it actually builds a rapport for the surgeon with the staff. You know who's in your room. There's no rotating technicians. There's no rotating nurses. It builds efficiency and also decreases staff turnover. From a patient standpoint, really lower cost options for self-pay patients. If you have a self-pay patient who needs cataract surgery and they go into a hospital or an ASC, you're now decreasing at least the facility fee cost by doing the cataract surgery within your own in-office suite. There's a rapport that's built with patients. There's greater satisfaction and greater familiarity with the environment. Just imagine being a patient meeting your doctor in the office. Now you have to drive across town, meet a whole set of new staff to help you. And it builds angst within the patient. There's increased convenience for the patient. They already know exactly where the location is. They've been to your office. They know your staff. You can create a boutique feel, and that convenience really has been correlated with higher conversions to premium IOL upgrades, which means more money for your practice. And the last 2 points for the advantages is that some procedures that take longer, you can do them in your own office suite, and you don't have to be exposed to the ASC saying that you're taking too long and you're not making them enough money. You can do everything in-house. And an important point is during the pandemic, when the ASCs were limited, there were some surgeons still performing surgery within their in-office OR suites. And it's actually proven to save some practices. So who's doing this? So it wasn't surprising to me that Kaiser has been doing this since 2006. There was one study that they looked at cases in Colorado in the metropolitan area where their staff includes 2 advanced cardiac life support certified registered nurses, These nurses are board certified. One nurse is used as a circulator, and the other one is used to monitor and chart. And also there's one surgical technician that's assisting the surgeon. There's no anesthesiologist unless it's deemed necessary. No IV lines or injections, again, unless it's deemed necessary. And they're only using topical anesthesia and oral triazolam for sedation. So in this case series study, there were 21,501 cases at 3 locations that were looked at between 2011 and 2014. These 3 locations, it's important to note that 2 of them were actually attached to a hospital, and the 3rd location was one about 1.5 miles away from a Kaiser-affiliated hospital. The surgical protocol was that the patient should have seen a PCP within 1 year of their surgery. The chart review was done at the initial cataract evaluation and closer to the time of surgery. If IV sedation was going to be used, then pre-op planning on the day of surgery would make sure that the patient was NPO, that any pertinent labs and imaging was reviewed, and a brief physical exam. And what they have there is an emergency response nurse stat team with a crash cart on standby in case of emergency. So just as a review, there's 3 classes of anesthesia classification. For in-office OR suites, Class A and Class B are acceptable, with the exception that if you're moving into Class B, that you should consider hiring an anesthesia professional. Patient prep. So what's the patient responsible for? So 1 day prior, they're responsible for using their antibiotics and steroids and NSAIDs. The day of surgery, they arrive 1 to 1.5 hours before surgery. Consent is taken, vitals are taken, the drops are administered. The anesthesia regimen is PO, topical tetracaine, retrobulbar was rarely used, and within the OR, we're monitoring the EKG, O2 sats, MVP. After successful cataract surgery, the patient is observed for 10 to 15 minutes, subsequently wheeled to the exit in a wheelchair, and their post-op meds are very similar to what we all use: 1 week of antibiotics and up to 4 weeks for NSAIDs and steroids. And their appointments are at 1 day and 1 month post-op. And the patients are responsible for self-reporting their adverse events. So of the 21,000 plus procedures that were looked at, only 3 patients actually ended up in the ED on the day of surgery. None of these were related to the cataract surgery, and all occurred after they left the facility. They never had to activate the nurse stat team. And the most frequent adverse events, really to no surprise, was iritis or uveitis 1 to 5 months postoperatively. And there was a less than 1% incidence of capsular tear, vitreous loss, RDs within 90 days of surgery, and there was no cases of endophthalmitis that was reported. So this is my last slide. So again, thinking about this, I was like, can I apply this at South Clinton? We have room on the 2nd floor. The patients who would be appropriate really are patients who have stable health. They have no significant health problems that will lead them to become unstable from a hemodynamic standpoint. Unfortunately, the left part of the slide kind of describes most of my patients: uncontrolled diabetics, uncontrolled high blood pressure, significant respiratory issues that prevent them from laying flat on the OR table, a very large BMI, and they require transfer assistance from the wheelchair to an OR bed. Thank you.
Great. Good morning, everyone. I have to figure out these buttons. So Dr. Coward did a great job. I was almost buying it in the audience. I'm like, oh, wait. So I'd like to go over the cons. So as Dr. Coward discussed, OBS is relatively new over the last few years, as opposed to hospital outpatient department or ASC surgery. They want to do it in the office. So the Ian Truliff paper that she went over from 2016 is really the only large case series that we have. And so it is pretty much the only thing that's been referenced in all these pro debates. So let's look a little closer. at Ian Shulev's outcomes. They have a great mean post-op BCVA of 20/28. They have similar or lower rates of intraoperative and postoperative complications, and they had 0 cases of endophthalmitis at 30 days. So you might be asking yourself, what's the catch? There has to be a catch, right? So I'm going to look at safety, feasibility, and reimbursement. So in terms of safety, safety is first. We're all physicians. We all want to make sure that our patients are safe and we don't want to do any harm there. So I did want to highlight, there are lack of established protocols. CMS does not have national OBS standards. And although they are accredited, they have less stringent requirements. They're accredited as offices, so they aren't as stringent as ASCs and HOPDs. And then let's look a little closer at Ian Shulev's paper. 2 of the 3 facilities were attached to the Kaiser Hospital, and the other one was only a mile away. So if things went south, they had backup. So what happens if a patient can't tolerate the surgery, you're having a complication, and you require more anesthesia? What are you going to do? You're going to just stop mid-case and move them to the hospital? Just think about that. All right, so I wanted to talk about feasibility now. OMIC recommends ASA class 1 or 2 for these patients. So PS1 would be non-smoking, no or minimal alcohol use. And ASA 2, which a lot of our patients fall under, is mild systemic disease, very limited medical issues, well-controlled diabetes, hypertension, and mild lung disease. So going back to the Ian Shulev paper, I wanted to highlight the systemic comorbidities of their patients. 50% had hypertension, about 20% had diabetes, COPD, CHF, asthma, or less. And then other selection criteria: avoid patients with anxious personalities who are uncomfortable with the slit lamp exam, so our so-called squeezers, and cataracts that are not complex. So let's, again, go back to Ian Shulev's paper. If you look at the ocular comorbidities, complicated cataracts such as polar cataracts, traumatic cataracts were less than 1%, axial length of greater than 26 millimeters, only 4%, pseudoexfoliation, only a little over 1%, previous pars plana vitrectomy, only 1% of the patients, and then only a 3% amount of the patients had a history of alpha adrenergic agonist use. So that is not typical with our patient population. And then intraoperatively, they noted pupil diameter less than 5 millimeters in only 4.7% and shallow anterior chamber in 0.2%. They didn't give the parameters, but I just wanted to ask all of you, how many of your patients actually fit these selection criteria? And would you want to take on that risk? Would it be considered malpractice? And we all know as surgeons, routine cases are many times not routine. So other feasibility considerations: experience is overall limited. There are very few studies on clinical outcomes and safety. You do have the extra cost of cross-training your own staff if they're going to be helping you out in this surgical suite, the cost of additional equipment and sterilization. And typically ASCs have the ability to negotiate cost of supplies and equipment due to the higher volumes. They have more diverse consignment because of the multitude of surgeons there, versus in an OBS, you're going to lose that negotiating power. You're going to have less flexibility in your treatment options. And then lastly, let's talk about reimbursement. So cataract surgery, most commonly performed surgical procedure, especially among Medicare beneficiaries. Medicare is the single largest payer for cataract surgery. Estimated 80% of cataract surgeries are performed on Medicare patients, which makes sense because of the age of our patients. And in order to maintain budget neutrality for physician reimbursement, CMS has been cutting reimbursement to surgical subspecialties to offset higher payments for primary care services. In 2021, Patel graphed out changes in Medicare reimbursement for commonly performed ophthalmic procedures. And as you can see, from 2011 to 2020, there's just been a drop in reimbursement. So what do they look at? CMS is looking at effort, risk, expense needed to furnish the service. And their rationale in 2020 for the 15% cut was average surgical time is shortening. Surgeons are combining post-op week 1 and post-op month 1 visits. And so my question to all of you is, will OBS lead to further cuts? The other thing that I wanted to highlight is, even though technology is allowing us to do faster surgery and more surgery, that's not a reason to cut reimbursement, but also, is it a reason to put patient safety and outcomes and quality at risk just because of decreasing reimbursement? Thank you. These are my references.
Thanks to everybody who participated in the debates. I learned a lot this morning. I think Steve has a microphone to go around to ask questions, and Fatima might as well. I'll get things started for a question for Ewer and Esteban. Any additional testing you guys would do prior to surgery in your Fuchs patients, spirometry, endothelial cell count, that would switch you from one side to the other side? Is there any minimal amount of spirometry or cell count that you say, I'm going to just do cataract versus triple, or is there any maximum amount that you say I'm going to do triple instead of sequential?
In before DMAC surgery, the making measurement is important, but the clinic is more important. If the patient has visual symptoms and if the patient has the epithelial problem, the edema problem, Bleu's problem, so it makes your decision to go to the surgery. Again, I'm advocating the triple. So whatever the clinic in what stage, if the patient started to be disturbed, so this is the decision. So I'm going to plan for the triple procedure.
Esteban, any reason that you would do a triple instead of sequential?
So I'm doing mainly sequentials, basically because as literature show, we have seen patients that people really need for their life to a perfect sharp vision. And of course, as I said, that depends on expectations and needs for each patient. But there are many patients that they just need a workable vision to be at home, watch TV, do a few other things, but they don't want to do shooting or drive a car at night, some things like that. So those are things I talk with my patients. For testing, I do mainly pachymetry, which gives us an idea of thickness and corneal function. Other than that, just the exam during the consult. And yeah, so talking with the patient to see expectations.
Okay. Rachel wants to chip in, I think.
Thanks. I just wanted to bring up that I think actually doing a topography is critical for these patients when considering a triple. And what we're seeing in our own experience doing triples and DMACs in general is that the posterior curvature of the cornea is actually really, really important to look at. Because as the cornea becomes more swollen and more edematous, the posterior curvature of the cornea flattens as the whole cornea gets thickened. And what happens after DMAC, which is a beautiful surgery, the whole cornea kind of shrinks back up and kind of becomes that beautiful arch again, but with that becomes a potentially big hyperopic shift. So it's really important to know how much the curvature is sort of distorted in your Fuchs patients, because what I have seen patients with upwards to 4, even 6 units of hyperopia after just DMAC alone, based on the changes in the curvature of the cornea. So I just wanted to throw that out there. I think what I've done in my own practice is really do those measurements and really talk to patients, say, hey, we're going to do this triple for all the advantages that, Ura pointed out, but you need to understand that there's some variability in that refractive outcome. And I think that's something that the whole field is sort of learning more about as we do more of these surgeries, but maybe a case for sequential surgery with DMAC first, because sometimes you get that huge change in refractive error that you can then correct with the IOL later, but it's an evolution.
Great point. Thanks, Rachel. Wen's got a question or a comment.
I have a question for Rachel and Ron. How close are we to something like a rapid strep for the eye? Urgent cares, they now do rapid streps and then send the culture and you wait. And if we're thinking that most of conjunctivitis is being treated outside of an eye provider, is that helpful? And then sort of a follow-up question is, do you feel like testing helps to decrease the maybe pressure on either providers or expectation from patients to receive antibiotics at the time that they're seen?
So with regards to testing, the whole kind of clinical micro field is definitely shifting towards more rapid molecular tests, right? PCR based and even just sequencing based, because PCR, I think Ron brought this point up, you have to know kind of a priori what you're looking for, right? And so now I think across the country, clinical micro labs are trying to move towards not just PCR, but more empiric kind of genomic sequencing based approaches for rapid detection. How soon that will come into practice, I don't know, but it's probably in our practice lifetime, I would imagine. In terms of the, kind of, I think you raise a really good point about the expectation of patients of wanting to take an antibiotic or wanting to leave the office with a prescription. And I don't know, Ron, if you have some advice on how you sort of negotiate that, but I think the culture is a way of telling the patient, saying, hey, listen, we're gonna pick your treatment based on what the evidence says, as opposed to, even though say, well, I think I need an antibiotic. It's like, all right, well, let's see what the test results say. But I don't know, Ron, if you have some advice on that.
I think part of it is you're talking about a 3-day wait till you get regular cultures back. I mean, in my mind, you really need to treat, to have happy patients. We don't get an MRI on every patient who has a headache. We try to, be judicious about what we order. And I would guess that Rachel would argue that we need to be judicious about what antibiotics we prescribe. Although, and you can correct me if I'm wrong, but topical antibiotics don't induce resistance to the same degree that oral antibiotics do. So,
well, we could, not that we're going to monopolize all the time, but so there have been studies like in the pre-op cataract kind of area where they looked at the efficacy, for example, of topical moxifloxacin before cataract surgery. And should we do that? And I think we all know that really betadine is the only thing that really has been proven to prevent endophthalmitis after cataract surgery. But what they showed was with the topical moxifloxacin pre-op is that not only did it have no impact on endophthalmitis rates, all it did was induce resistance on the ocular surface. So it may not be to the same extent as an oral antibiotic in terms of inducing resistance into your normal kind of gut flora. But I do think we should not take it lightly that a drop is kind of meaningless. It really does substantially change the ocular surface and drives resistance of bugs on the surface.
What has happened with polytrim in terms of this is your expertise. For instance, if you're looking to cover staph and strep, I wouldn't necessarily reach for moxifloxacin. I'd probably go with polytrim, or even Tobrex has better coverage, I think, than moxifloxacin. So does that change anything that you would recommend?
Yeah, polytrim is actually a really great drug, partly because it's a combo agent. So the resistance levels to the combo together are low and much lower than fluoroquinolones. The downside of polytrim is it has kind of a slower kill rate. It doesn't get into the eye as much. It's not effective against biofilm. So there are some inherent limitations of polytrim, but for mild conjunctivitis, it's a great choice and would be my personal preference over fluoroquinolone just based on resistance levels alone.
Yeah, I have a question for Dr. Wozniak. So, I see a lot of conjunctivitis patients when I do comprehensive in Batavia. Sometimes, they also show up in my uveitis clinic. So do you actually culture your conjunctivitis patients? That's number one question. And number two, what kind of cultures do you send? Like blood agar, chocolate, anaerobic, or I just want to know what kind of cultures do you send?
So is the question, do I actually culture my patients? Okay, fair enough. How do I answer this? No. But I also don't empirically treat with antibiotics. So it's, I do culture in cases where there's diagnostic uncertainty, it's chronic, they're not getting better, it's severe, anything that's out of the norm, I will. And I think Ron would agree with that too. I think, typically if they're referred to cornea services because something else is going on, they're just not getting better. But I don't, I almost never prescribe empiric antibiotics unless I have a really compelling, reason clinically to do do so. So I always go the route of just sort of reassurance, tears, close follow-up. But yeah, so I guess the answer is sometimes, we'll just culture whenever there's any uncertainty or, confusion or anything like that, I usually culture. Would you agree?
I would actually go a step further to say that when I do telemedicine visits in patients that I know, I will treat antibiotics without seeing them. Because it's really the same thing, that the likelihood that they have anything more severe, as long as they pass your screening test, is pretty low. And you can always regroup if they're getting worse. You can always touch base with them. There's a lot of things you can do to make sure that your decisions are good ones. So, I think you can argue, you and I talk, we flipped a coin on who's going to argue what, because it's really a matter of using good common sense, I think. But it's a big difference. I mean, someone walks in my office with a gooey eye, they leave with antibiotics.
I think Andy just pulled back the curtain on these debates that maybe they're not as strong as we feel. Dave, you got a question? You were, go ahead.
I have one question for Vin and Dr. Shifera. For Irving gas syndrome, what is your approach for local, and what do you think is there any oral option steroids for the Irving gas syndrome?
For
Resistant cases.
Irving gas syndrome, right? So I mean, the main problem is macular edema. So I treat that, with steroid drops. Durezol is very effective for CME. Rarely have to do steroid injections. I've never used oral steroid for Irving gas syndrome. So Durezol first. If that doesn't work, steroid injection. Usually it goes away within a year. Most of the time, I've seen some patients just go beyond a year after surgery, but usually it goes away within a year.
I agree. I think topical steroids, topical NSAIDs, I'll sometimes escalate, Bromfenac twice a day, Durezol 4 times a day, and I'm not hesitant to leave them on that for a really long time if they're responding and do a very, very slow taper. I think the risk of that is less. I think if you had to push and they were not responding, you could do a trial of oral steroids just to see if something would be beneficial. You can't keep them on that for a long time. And then if it rebounds and recurs even on all your topicals, then probably would go for an intravitreal injection.
A question for Amde and Wen. 2 questions. One, just could you comment on the utility of the Retisert implant for uveitis in general, your personal philosophies? And 2, do you use a proton pump inhibitor or a H2 blocker when you put patients on steroids?
Okay, so the first question, I have never used Retisert previously, but I just had one patient who came just a few weeks ago. He has posterior uveitis. Most of the macula is gone. His counting finger, so he has lost a lot. For that patient, that would be my first patient when I recommend Retisert, and he will see you in a few weeks. So, I try to save as much as possible. If you get a Retisert, you have a big foreign body in your eye, and you'll have another foreign body a few years later, and you'll have to have glaucoma surgery. You'll have to have cataract surgery. So I try to stay away from Retisert as much as possible. But I have one patient, and for that patient, I'm recommending Retisert. And second question was, sorry.
Yeah, I think about Retisert as sort of my last resort, but it is helpful in a subset of patients. Retisert does work. The data shows that it works as well, or if not better than systemic therapy. It's just a lot of ocular side effects, which we can manage, right? We can treat the cataract, we can do glaucoma surgery, but when you counsel them, you're saying, we're really signing you up for 3 surgeries. And sometimes you just do some of the things at the same time. The candidates, I think, for Retisert, where I think about it earlier, are patients, for some reason, they can't get systemic therapy,
or you're really concerned about follow-up. And it's severe inflammation. They need control of their inflammation, but either they can't get systemic treatment or they're not willing to come back or take their systemic treatment. Those are the patients that I think are the really good Retisert candidates. What I would love to see is sort of a comparison of systemic therapy with YUTIQ, like a 3-year injectable implant. I think anecdotally, uveitis specialists feel that YUTIQ is not as effective as even Ozurdex. So I don't think it's going to replace systemic therapy in the way that I think a Retisert actually does replace systemic therapy.
As far as PPI and H2 blocker is concerned, for almost every patient, I put them on H2 blocker or PPI inhibitor until they are at 10 milligram or below. And I try to avoid like ibuprofen and indomethacin while they are on steroids at the same time. So it's I mean, most patients will have symptoms like GI symptoms, burning and something like that. So that's like a very common side effect. And I just want to add about weight gain. Some people are very unhappy about weight gain. It's very important. Some people pay a lot of attention to their body. So the weight gain, it can happen quickly. It may take a while to go away. So it's a very common side effect.
We have a board certified rheumatologist here. This is Dr. Anatole Kleiner, who I've been working with on a joint uveitis rheumatology clinic. I'll defer that question to him.
So hi, everyone. Good morning. In regards to steroid usage, a lot of times in the rheumatology field, we will depends on the dose that we're using. So, I mean, if you think about it, these patients, when they come in and they have a problem that requires large doses of steroids, they're critically ill. You're adding one medicine and then potentially 3 or 4 other things, PPI, bisphosphonate. So, you have to always temper that in terms of overwhelming the patient. So when we use large doses of steroids, 0.5 milligram per kilogram or above, we're usually using a PPI in addition. And oftentimes these patients are on a bisphosphonate too.
Great, thanks. I've got a question for Christine and Janice, since we haven't asked you questions yet. Let's assume that Santa Di Loretto brings you your office suite and you've got an appropriate stream of appropriate patients. How soon before you get our residents doing office-based surgery with you?
I think I'm unlike anybody else. I'm ready to put them in the driver's seat right away. I of course would do it for a couple of months, and then if everything seems okay and we have the perfect patient, like I showed on my slide, somebody stabled, no one who's going to code on the table in South Clinton on the 2nd floor. That's where I want the OR. But yeah, so if we have a stable patient, I would have them do it with me.
Okay, Janice. Let's say you buy in, because we know these debates aren't really real, but if you're
I'm buying in now.
You're buying in, yes.
You've
seen the light, Christine.
I guess, the other thing that I didn't mention is that, not only are you the surgeon, but you're also the person that's going to have to be there as backup if they're, they have anesthesia complications or they, any other issues. So I guess it's good to have an extra MD in the room is my answer. But yeah, I guess I think the residents do topical cases now. So, as opposed to when we were residents and everyone was blocked, I think, it's a good practice for them.
And then one more point, I think everything that we do here is to prepare them for the real world. I mean, after they leave the home of residency, they may go out to the real world and be doing this at their own private practices. So why not let them do as much as possible while they're here with us?
Okay, any other questions from the group? Yes, you're.
Okay, yeah. I want to just do a comment about the office-based cataract surgery. Maybe I did more than 2,000 in Turkey because we don't have anesthesiology everywhere. And the problem is, this is the reality. And the problem is in the United States that I realized that the patient's expectations is really high. So even we plan, and I would like to plan, but even we plan, the patients are getting information from each other, from peers and from relatives, and they want to be more relaxed. They want to be more comfortable during the surgery. This is the one of the issue that I realize in the United States. Another one, in Turkey, even we don't have efficient or sufficient anesthesiology. We have one anesthesiologist rotating in the rooms, and it was like circulating anesthesiologist, and he's helping just in case, helping the room. So this is a good seatbelt. So here, if the anesthesiologist is not involving the surgery, don't touch the surgery. So it is awkward for surgeon, actually. It's thinking again and again. Even the rates is from Kaiser's study, excellent, but the 3 cases that emergency department visit in 21,000 cases. So that's my comments.
So you want to do it or you don't want?
I want, but just give me a phone number of anesthesiologist. That's all.
Yeah, I think with proper patient selection, whenever I have done it, I think it's important to establish the carrot for the patient. One patient had a meal, but still wanted to proceed because it was hard to organize coming back. Another patient was afraid of IVs, and so they were okay with having to do it just topically. And if you establish the carrot, that's what they'll be thinking about during the surgery, and at least it makes things a lot easier. The other things I was thinking about was, in GI procedures, they have a nurse or a technician holding the patient's hand. I think in addition to like tactile feedback, it informs, it comforts the patient. It also lets the person holding the patient, if there's a code or at the beginning of a code, you'll start to know that soon enough. And I think it's important to have an O2 sat on the patient all the time. Again, that becomes a problem because you have to somehow get it into e-record. And lastly, we should be able to do blood pressure monitoring. That's a problem getting it into e-record. The last thing is, like Ur mentioned, I think the anesthesia team, like they wash their hands of any local case because they're not getting paid. So we have to come up with a different, model wherein, let's say you had 5 rooms running, and then anesthesia just has to be circulating or around for those 5 rooms. Then it might be worth their while to spend to be there for us.
Karen.
Because as Jen said, once Medicare starts looking at the numbers, the time, the amount of staff that's involved in this procedure, the first thing we're going to do is cut that of surgery. So eventually we will get there, but we don't have to rush it because we have one study to look at. That's the only study they have. The more we start doing this, they're gonna have more studies, and then advocacy is really tough. We go there, we fight every single year, and we hear the same things over and over. So they're just waiting to cut cataract surgery because that's one of their biggest expense. So we have to look at it in that light, that eventually, once it becomes an obvious procedure, they're gonna cut it almost 50%. Right now, we're only getting paid like almost $800 or less for cataract surgery. At one time, they were getting paid $2,500. So once obvious procedure where they think that it's not as if the risk is lower and the time involved, and you're going to need one surgeon, no anesthesiologist, no, then it's going to be the product that is pretty much then everything else is going up, but the reimbursement is going down. So that's one of the things that we have to look at. Not trying to rush it.
Okay. I think we're up against it. Mithra has one last question or comment.
So I'm so excited to have that conversation. I think that as we look at the various trends of the healthcare system and the incentives that it applies, it is driving us in certain directions. And so, for example, de-escalation is one of those directions. Those procedures that were historically performed in hospitals and required admissions end up being moved to ASCs and are outpatient. And similarly, those that were performed in ASCs are going to be pushed into the office. So, those trends are occurring regardless. Completely agree with Karen. It's about timing. And I think that there is a good time to get into that space. And it's going to, I think, be a few good, very good years. And then it catches up because the healthcare system is designed to extract those efficiencies as well. So I'm delighted to hear this discussion in such a broad forum. Thank you.
And I think that's it for this session. Thanks for all of our speakers and their spirited debates. We're back at 10:15.